Hi everybody, it's Liam here from Myriad Australia. I'm the International Philanthropy Manager, and we work with a network of international NGOs to support and enable their fundraising through the Australian network. I'm here with Dr. James Tibenderana, and he is the CEO of the Malaria Consortium. How are you today, James?
Very well, Liam. It's good to be here. And yeah, it's good to talk to you and the network of supporters that you have in Australia and hopefully around the world.
Yeah, look, I'd love to learn about your story, right? Because you've been working in malaria and public health for over 20 years now. How did you get into this field and what have your experiences been so far?
Okay. Yeah, I think it's the classic story. Having gone through the experience of malaria several times, as I think my first attack of malaria was when I was about 2 years old, and consistently getting anywhere between 2 to 3 episodes of malaria every year until I was a teen. And it's an experience you go through, and there's a point I said to myself that whatever I can do to prevent anyone from going through that experience was what I would dedicate my life to. And so I was very determined to initially become a medical doctor, which is what I did. And throughout that time, malaria just kept, ringing that bell in my mind that if there's something we can do to prevent anyone from getting this disease and eliminating it, it's got to be done. Now, and then I crossed into public health and joined Malaria Consortium in 2005. And it's been my passion to see what we can do to eliminate this disease from the world.
Wow. Wow. So look, what I love hearing is just it's the cornerstone. Your leadership is based on lived experience as
Yeah.
well as from your experiences growing up and that fire burning within you. So 21 years later, still fighting the
Yeah.
fight for malaria.
Yeah. It's a long journey. Even the medicines, chloroquine was very bitter, quinine very bitter. And I remember meeting a manufacturer and saying, why don't you make these medicines easier to swallow? Imagine having to take these bitter pills. And I think that was the opportunity for me to realize what one can do when one has the opportunity to interact with stakeholders. And what I've seen over the last decade or even 2 decades is when the funding is available, the dedication, the commitment, and the stakeholders, a lot can be achieved.
Fantastic. I've actually taken some malaria medication myself. I think it was called Malarone. I
Yeah.
experienced funky dreams. So look, I'm
Yeah,
glad that the side
exactly.
effects were not as adverse as yours. But
Yeah.
yeah, Papua New Guinea, when I was used to working through that time. So it was a
Yeah.
preventative medication for us at that time. Yeah, yeah. But your work spans globally. I'm fascinated to know where you deliver your your programs and your work. I'd love to hear the work that you do globally.
So Malaria Consortium is a global international organization. We're a UK registered charity, so our head office is in the UK. We have 11 offices around the world. We have offices in Southeast Asia, Cambodia, Thailand, Myanmar. And then in Africa, we have offices in Mozambique, Ethiopia, South Sudan, Uganda, Nigeria, Togo, Chad, Burkina Faso. And that's where we have a physical presence. In some locations, like in Bangladesh, Nepal, and more recently, we're starting to explore opportunities in Papua New Guinea. We have activities, it could be research activities or technical support activities to national governments or to partners. So in Cameroon, in Tanzania, in Malawi, we've had various activities that allow us to support our national partners as well as carry out research as well as technical assistance. Now, with those locations, I would say that we cover some of the different epidemiologies of malaria as well as communicable diseases. So Nigeria has one of the highest burdens of malaria globally. It really takes a huge chunk of the burden of malaria cases as well as malaria deaths, all the way up to a place like Cambodia, which is on track to eliminate both falciparum malaria and vivax malaria by 2030. In fact, I think they're about to start a certification, which will demonstrate that for the last 3 years, they have not had indigenous transmission of malaria, meaning malaria that originated within Cambodia. So we have a broad spectrum, both in terms of high burden as well as malaria elimination. At the same time, we also cover different types of health systems because delivery of services goes through health systems. And some health systems are fairly strong and some are quite weak. Or you have primary health care, which includes community health workers, or primary health care, which is largely based on health facilities. So we cover that spectrum of countries as well, which enables us to be able to test and deploy interventions in different health systems and in different malaria transmission intensities. I think this is something that's quite unique about Malaria Consortium. And then I can of countries as well, which enables us to be able to test. We go from prevention, in other words, making sure that a child or an adult is prevented from getting malaria, either using insecticide-treated nets, which is a bed net. One sleeps under the net, and because of the insecticide that is impregnated into the fiber of the net, the mosquito, when it comes into contact with the net, is either killed or because the repellency effect discourages the mosquito from coming close to the net. Then we have chemoprevention, which is the use of common medicines like sulfadoxine, pyrimethamine, that can be given to a child less than 5 years of age, and it's given to that child once a month, preferably, and the target is during the transmission season in a strategy called seasonal malaria chemoprevention. So the child gets, so that's on the prevention side. There's a host of other things that we do with regard to prevention as well. But then I'll move to what is called case management. In other words, the diagnosis and the treatment of malaria. Diagnosis is carried out using either a rapid diagnostic test, which is a simple kit with a drop of blood and a drop of buffer that enables a layperson or even yourself or myself to carry out the test to identify whether one is positive. And then if one is positive, taking the right antimalarial for that location, and that should clear the parasites. So that would be the basics of the kinds of things we do. Of course, there's other things we partake in, for example, strengthening the health system, making sure that the supply of medicines, the supply of diagnostic tools gets all the way to the last mile, to working very closely with community health workers who are based in villages, in communities that are able to work closely with households to ensure that children and adults get tested or are able to get their preventive tools. So that's sort of the basic core of the kinds of things that we do.
Wow. So what I'm hearing is such incredible breadth and depth of your work as well. So working with governments at the top level, right? But at the community level and the ground level as well, educating community health workers and doing the day-to-day prevention work and then treatment work as well.
Yes.
In terms of what you do with building the system and changing the system, how does health equity come into that for those, you're talking about last mile, right? There's hard to reach communities in really regions that have so many crises going on simultaneously with conflict and climate as well. And then on top of that, you've got malaria. So I'd love to learn about, your work and your definition of health equity in your work.
Yeah, it's a convergence of I would say many domains. The equity lens is critical for malaria elimination because to get rid of the parasite and to prevent the mosquito from picking the parasite, you have to ensure that nobody is left behind. The vectoral capacity, in other words, the capacity of the mosquito to transmit malaria is so high that the transmission potential of malaria is even far greater than measles. It's greater than Ebola. It's greater than HIV. It's greater than COVID. So the mosquito has the capacity to pick parasites from individuals and spread them around to multiple people, especially if those people don't have immunity, like, and who are starting to build the immune responses, and the malaria parasite gets into those kids, it's an infection and becomes severe malaria quite quickly. So the mosquito is the intermediate host that makes malaria so easily transmissible within communities. And so if you, of one, is not able to reach everybody in that community, just one person has the capacity to spread diseases within their local ecosystem. And this is why equity is such an important element to our work, whether malaria or some of the other diseases, because unfortunately, the systemic barriers that prevent individuals from accessing the health system means that they then carry the larger proportion of illness, whether it's malaria, pneumonia, diarrhea, or vaccine preventable diseases. And when you look at, cost effectiveness as one of those domains, cost effectiveness is about reaching, the majority of a population with a proven intervention and ensuring that they're able to experience the impact. Cost effectiveness can miss out on equity because, for example, in Cambodia, where they're, on the last mile, just 1,000 cases that they're tracking, to reach those 1,000 cases requires community health workers or village health teams to be reaching out everywhere because you just don't know where that next case is going to spring from. And if you allow that case to establish itself, then you have a micro epidemic taking place in that location, or you create hotspots. So you have, Cambodia going for elimination, 1,000 cases, less than 1,000 cases, and the system has to reach every one of those cases, diagnose them on time, treat them on time, and ensure they don't transmit. So that's equity. Compare that to a place like Nigeria, where you have, the population size in much of Nigeria, you have, thousands of cases in local government areas, which is the smallest denominator, and the system has to cope, and yet the numbers are so huge. So it's burden and equity. If you want to eliminate whether malaria or any disease, you've got to use the equity lens because you can't afford to leave anyone behind.
Wow. Wow. It's in, it doesn't discriminate malaria, right? Doesn't matter you're rich or poor. If one person has it in the community, it can very spread and mushroom and balloon the numbers very easily. And so you have
Yeah.
to address it for everyone.
Yes. I mean, we've seen it in Ethiopia. Ethiopia is one of those countries that in Africa that is known to have a fairly strong health system because they have established community health workers who operate as close to communities as possible. And they've seen cases rising. Thinking 2021, they had just 1.3 million cases. And in 2024, they had 10 million cases of malaria. And that's because, breakdown of the system. Ethiopia has been going through, some civil strife, breakage of health systems. They're experiencing a new threat called Anopheles stevensii, which is a mosquito that is able to transmit area in setting. They've had internal migration. They have populations that are not sort of immune. And so when they are infected, you have transmission taking place quite rapidly. So it's an example of what can happen when the system breaks down, or you have internal migration of populations who are not in an area with malaria, moving into an area where malaria exists. And, it just triggers an increase of cases. And this is, I think, one of the challenges we find in our health system and in our work, that we've got to be agile, we've got to be flexible, we need to be capable of responding to some of the dramatic changes that take place within health systems, or within communities.
So how did Cambodia get to where they are at the moment? Because you're saying by 2030, malaria could potentially be eliminated, full stop, right?
Yeah, yeah, I think that they're on track. And
Mm-hmm.
it's been a long journey. So these are the two common types of parasites in Cambodia. Falciparum causes very severe malaria, while Vavax causes what is called relapsing malaria, where you can get infected, the parasites hide in the liver, and then the parasites reestablish themselves. But Cambodia is on track to eliminate both, and I think has hardly had any cases of falciparum malaria in the last few years. So, that's an amazing story. So what have they done? I think it's focus and the fact that malaria elimination has been something that has been a priority. When artemisinin resistance, started in Cambodia, everybody tried to contain it, putting in place the measures to hold it back. And then quite quickly, over five years, the realization was we couldn't contain it. And instead, the shift was to elimination. Rather than trying to contain the parasite and limit spread of artemisinin resistance, the strategy that WHO and partners agreed on was to eliminate the parasite from Cambodia and any of the locations where artemisinin resistance was present. So the Greater Mekong sub-region went for a regional strategy for eliminating malaria. And that's also key, the fact that the countries worked together as a region. So it wasn't just Cambodia, but it was the Greater Mekong sub-region saying, this is what we want to do. So working across borders, sharing information within the countries to make sure that they were putting in place the right strategies to bring the numbers down. Village health workers, community health workers who are in the communities, working with communities and understand the context. There's quite a bit of seasonal workers who go into forests, who move around the country. And because of the extensive village malaria health worker program that they have the capacity to detect cases early and to give treatment as quickly as possible before transmission establishes itself. The village malaria workers are also able to determine when there's movement. When workers go into the forest, they pick that information early,
Mm-hmm.
and there are posts, they locate posts where communities cross into the forest, and they're able to provide testing, they're able to provide insecticide-treated hammocks, they're able to provide information. And if a worker experiences a fever on their way back into the communities, they're able to get tested so that they don't carry malaria from the forest into their communities or into their urban settings. So an extensive network of village malaria health workers. Cambodia also has a very strong surveillance system, a system of tracking cases, putting that information into a centralized pool, and then the Ministry of Health, the National Malaria Program, is able to use that information to decide on how to react, to decide on what drugs to bring into position. That is real-time data that the country has had and have been very, very effective at using to ensure that they're able to control cases. And then determination with a vision, and the fact that it's a it's a long game. It's not a short game. You've got to think about the long-term strategy, and how, as a country, one is able to detect cases, to treat them, to put in place the right financing mechanisms, whether it's with domestic financing or with partners, philanthropy, multilaterals, bilaterals, and put that money into the most effective strategies.
Wow. So the system and all the players are really coming together to really eliminate this in Cambodia. It sounds very comprehensive. What are the risks? Because look, we're talking about a regional response, right? Like Look, silly turn of phrase, but mosquitoes can fly across the border from other
Yeah.
regions, right? So
Yes.
it makes sense that it is a regional response, but sure, you can eliminate it in Cambodia, but what happens if mosquitoes fly from across the border?
Yes, that's why it's got to be, a cross border as well.
Yeah.
Now, China used, that had that in mind. Excuse me. So one of the things that China did in part in its elimination strategy was to think about their borders. So
Hmm.
the Chinese government supported countries across the border who had malaria to contain malaria in the locations that were close to the border. So they didn't just focus on China, but they went even further and said, okay, let's support countries that are experiencing malaria transmission to ensure that we can break that transmission to prevent malaria from getting to China. South Africa is also doing the same thing. So South Africa supports the Mozambique government at the border to ensure that transmission, all right, at the border with South Africa is sort of reduced. So you have examples, in other places as well, where national governments are cooperating with each other. When you're flying distance, a mosquito can fly up to a kilometer, on its own, and up to 7 kilometers with the aid of wind. So as you said, 7 kilometers reach, you could have a mosquito that picks a parasite here and with wind, can cross over. Then mosquitoes can be carried, suitcases,
Hmm.
bags,
Yes.
clothes, right? They can be carried and they can move, within a location or they can cross borders. So one of the things I would say that is an important element of malaria elimination is countries collaborating with each other. So cross-border activities. Elimination 8 in Southern Africa is the countries within the Southern Africa region are working very closely with each other, similar to what the countries in the Greater Mekong sub-region are doing. And I think governments appreciating the need to share information and where there are borders, communities actually, what I've seen in some places, communities don't even have a line and they say, okay, this is one country, this is the other country. They are crossing, they're engaging with each other, they're partaking in farming or other activities, but making sure that those communities are able to share information. And when they deploy an intervention, like for example, seasonal malaria chemoprevention or insecticide-treated nets, they do so in a manner that ensures that those locations are covered. When we deployed in northern Nigeria, the first time we deployed seasonal malaria chemoprevention at the border between Nigeria and Niger, children crossed over from Niger into Nigeria to receive seasonal malaria chemoprevention. And what we then did, with the Nigeria government working closely with the Niger government, was to synchronize the timings when seasonal malaria chemoprevention was given so that the two communities received seasonal malaria chemoprevention at roughly the same time, and therefore there was no need for crossing borders. Same thing with
Yeah.
nets, insecticide-treated nets. If countries work together to have the campaigns or to have the distributions synchronized, then you reduce that need of communities crossing over or nets leaking through the system into another location where those nets may be used effectively, but outside the domain of that particular country.
Cambodia is next on the radar to be malaria free as well.
Yes, and I'm happy to say that we've contributed to Cambodia's journey, and I think it's a multi-stakeholder journey. It's got to be led by national governments. They've
Mhm.
got to be in the lead, and partners like ourselves will do as best as we can to be able to support. But it requires, philanthropy, it requires multilateral because predictable funding is a
Mhm.
key element of that journey.
All right, where can Australian donors participate and how can they, yeah, be a catalyst for change in Cambodia and to other regions as well? Because you're saying the governments are leading, but you do need philanthropy to play a role as well.
Yes, yes. So I think a very I think important contribution would be, as I said, potentially ensuring that there is consistent funding, donations, no matter how small, because it's about persistence rather than perfection. Being able to plan, being able to be meticulous about what gets delivered, and working with communities to build that trust. And so, if one has consistent funding, technical expertise, and as I said, national governments being in the lead, there's a very good opportunity to make progress towards elimination as well as reducing some of the other diseases. So funders, we have on our website, we have the opportunity for funders to be able to engage through Myriad Australia. They can look at some of the programs that we have. We prefer unrestricted funding because that gives us the ability to plan, to target, to deploy, but we also have programs where funders can choose which particular program to support and make those donations through yourselves in a tax efficient manner so that money gets to us in time. But as I've said, I think what I would encourage is that persistence, that consistency. So whatever funding it is, it's just making a commitment to provide that funding on a regular basis. It could be monthly, it could be annually, but looking at a long-term strategy rather than a short-term strategy. And then, giving us feedback in terms of how we're doing. There's opportunity to reach out to us through, again, our website or directly to myself or some of the experts to let us know what we're doing right and what we could be doing better.
Seems to be, to me, through our discussion so far, there's so many ways to contribute to Malaria Consortium and then the fight for malaria and other diseases as well, right? From your systems level change and designing the systems to the very preventative mechanisms in the mosquito nets that are treated and the preventional medicines as well.
Yes, yes. I would look at it from the lens of a child. So,
Mhm.
a child goes through a variety of illnesses, common childhood illnesses, whatever location that child is in. And then that child, fits within a household. So the child has caregivers who look after the child, and therefore a pregnant mother who falls sick, all right, is potentially not going to be available to look after herself, look after her pregnancy, or look after children in the household. So making sure that a mother who's pregnant, has preventive tools, whether malaria or prevention of some of the other diseases that will occur during pregnancy. And then you have the dynamics in the households, the economic productivity of the household, and how are we and others contributing to ensure that that household is economically productive so that the child is able to get the right nutrition, the child is able to go to school, be educated. And out of pocket expenditure in many of our countries is so high because communities don't have access to all the services at the primary healthcare level. So they'll spend money going to drug shops, they might spend money because a child has fallen sick and has to be admitted in hospital. And at that particular point in time, some households may not have the money, but have to borrow it. So looking at the economic situation around that household and the fact that children who bear the highest burden of disease tend to come from households at the lowest end of the poverty spectrum. And then thinking about the system, if we can bring a net to that child, then why can't we bring other things to that child as well? If we can bring seasonal malaria chemoprevention to that child, we can also pick information about that child's immunization status or information about the child's malnutrition status, and then use that information to guide the household on where to go for those services or take that information into the health system for the health system to be able to react. So if you look at it from a child and how are we supporting and facilitating the child to be healthy as the child grows into, a toddler, a teenager, You could then see the logic in terms of using malaria as the entry point into child health and using malaria as an entry point into strengthening the health system.
Wow, that's really incredible. The cascading effect of the system in place to fight malaria, but then also expand because the system is in place to prevent other diseases and for other broader health outcomes as well.
Yes, yes, yes.
You mentioned earlier in the conversation about cost effectiveness as well. I'd love to learn about, yeah, how you address the economics of delivery of preventative medication or the nets, as well as the system as well.
Yes, cost effectiveness is a key metric that I think is something that Malaria Consortium recognizes as a decision point for funding, but also a decision point to determine the kinds of tools to be able to implement in a particular setting. And what we've been able to show with our work, because Malaria Consortium plays different roles. So we generate evidence as well. We evaluate, we carry out research to show that tools are feasible and acceptable in communities. And we very, I would say, systematic about how we scale up tools, because you can have a demonstration project with a couple of 100,000 participants, and over time you want to be able to reach a significant number of the population. So with seasonal malaria chemoprevention, we started off, I think our first project around 2014, 2016 was about 150,000 children that we're reaching. At present, we reach almost between 23 to about 24 million children per year. So from 150,000 children to 23, 24 million children shows you what can happen if you systematically think about how to scale up, how to reach a broader population level effect in a manner that is sustainable. Because with these things, you don't want to go to scale and then dramatically drop, because you lose the impact that you've created. But we are very systematic thinking through how do we take things to scale. As you take to scale, the cost effectiveness metric changes. You have potentially a tool that is proven to be efficacious. In other words, it can do the job, but may not reach high coverage. And as you take it to high coverage, then the cost effectiveness of that tool increases. So that's something we pay attention to, and we've demonstrated it with seasonal prevention. We've demonstrated with insecticide-treated nets, and we've also been able to put data to show that things like vitamin A, when combined with seasonal malaria prevention, can also be highly cost effective. And we're doing other work to show that putting together oral rehydration salts for diarrhea in children, putting that together with seasonal malaria prevention can also be cost effective. So it's a metric that we use. It's a metric that's important to us. But as I've mentioned, it's a metric that we are conscious does not facilitate equity as a primary focus. So we have to bridge that gap between cost effectiveness and equity. So where a tool may not be cost effective, we will, as Malaria Consortium, still want to work with that population because we want to make sure that no one is left behind.
Fantastic. And it emphasizes your point earlier on the fact of consistent, regular funding to come in to enable the system to maintain the work and its impact as well.
Yes, consistency is personally, I would rather have small and consistent than big boom and bust. It's, over and over again, you see the fact that if you can be consistent, Cambodia went through, some funding disruptions, last year and the year before, and we were able to step in quite quickly to provide that consistency in some of the work that they were doing. Without that consistency, you could have a situation where indigenous transmission in Cambodia returned, which would then have meant that their target of eliminating malaria, all forms of malaria by 2030, would not have been met. So consistency and persistence, I think, is key. Whether malaria, we even see that in polio. Same thing with polio. I think we're all surprised with measles. Suddenly, we're seeing measles outbreaks in Europe, in Africa, and yet measles is something that I think I saw my last measles case in medical school, and since then, I haven't seen a measles case, and so it's
Mm.
shocking to me that measles is back. Right. So
Yeah.
persistence, working closely with communities, ensuring that communities have access to the services that they need as close to them as possible, I think is key.
Yeah, of course. The James World Malaria Day is coming up on the 25th of April. Is that right? Tell me about that day and the significance of Malaria Consortium.
World Malaria Day is usually takes place on the 25th of April every year. It's an opportunity for all stakeholders, governments, communities to reflect on their role in bringing an end to this devastating disease. So it gives us the chance as an organization to be accountable to our partners, to the communities that we serve, to the funders, to ourselves, to reflect on what we've been able to achieve, where we are, and what else we should be doing. So it's an opportunity, I would say, for accountability and collective, visible accountability at a global scale. In locations where we operate, we will usually have one or other activity taking place. Some of the activities are to raise visibility to the devastating impact that malaria has. And in some locations, we'll be working closely with our stakeholders to see what we can do to raise funding for various causes within the work that we do. Globally, create that momentum to fund malaria and to see the end of this disease that I personally would want eliminated from the world. It's also a time when WHO and rollback malaria partners tend to each year have a theme to remind us of what our responsibilities are. And I think the theme in 2026 is driven to end malaria. Now we can, now we must. And that's the rally call, because malaria progress has stalled over the last couple of years, and we all need to be doing what we can not to let go of progress
Mm.
because there's so many threats, but to take, I would say, really.
Let's quickly touch upon vaccines. Tell me about the malaria vaccine at the moment. Where is it up to and the progress dispersing that through the community?
The malaria vaccine took over 30 years to develop from, lab all the way up to starting to scale it up as a result of WHO's recommendation that the malaria vaccine could be used to protect children who were at risk of malaria. And up to about 25 countries or maybe 26 countries have been able to deploy that vaccine within the last few years. And I think that's one of the, I would say, fastest rollout of a vaccine in terms of geographical reach, because it's been one country after another. But what I think we are all seeing is the commitment and determination to roll out that vaccine has been so high, but there have been, some system challenges that have meant that a child who needs to receive 3 doses struggles to complete those 3 doses or achieve a fourth dose. So for the malaria vaccine to achieve its full potential, a child needs to have received 3 doses and then 1 year later received a fourth dose. And that is that requires the child to come into the immunization program several times. So the first dose seems to get very high coverage, above 70% of children are receiving that dose. And then as it moves towards the third dose, less than 50% of children are receiving the third dose. And when it comes to the fourth, that's even lower. So there's a need to work within the system, to work across some of the barriers that prevent children from accessing the third dose and the fourth dose, to work with our stakeholders, to work with governments to ensure that that gap is bridged. Now, funding is an important element because the malaria vaccine, is one of the most expensive vaccines within the immunization portfolio, but the price of that vaccine has been dropping. I think it's probably just under $2.50 at the moment for one dose, and a child needs to get, as I said, 3 doses at various points between the age of, a couple of weeks all the way up to 10 and then 17 months. And then a fourth dose that the child needs to help boost the immune response. So there's commitment, there's determination, and communities, have had high acceptance, but there's some systemic issues that have been preventing the optimal deployment of that vaccine. We are supporting, working closely in all our locations where the vaccine has been deployed to understand what these systemic barriers are and to identify solutions, whether it's the supply side, making sure the vaccines get there, whether it's health workers who need to have the right training to give the vaccine, or communities ensuring that they understand the schedule of when to get those vaccines and coming for those vaccines.
Yeah. So immunity can only be guaranteed when the third and potentially that fourth dose is administered to the children.
Yes, 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 yes.
And then
And it's not an absolute vaccine. So you could call this the first generation malaria vaccine because the malaria vaccine is different from a viral vaccine. So a viral vaccine like measles, malaria vaccine is a parasite vaccine. Parasite vaccines do not achieve the high efficacy that a viral vaccine has. And that's because the antigens that are present in the vaccine to stimulate the immune response within a viral vaccine, one can identify a couple of common antigens that are then used, whereas with the parasite vaccine like malaria, there's hundreds of different antigens that display themselves at different stages of the malaria parasite that it's so difficult to be able to get the minimum number that one can use in a vaccine that can provide complete immunity to a child. So it's an imperfect vaccine if you compare it against a viral vaccine, but it still prevents anywhere between 30% of children getting an episode. And this isn't just about the number of children, but if a child, like I described myself, getting anywhere between 1 to 3 episodes per year, if you reduce that by 30%, that means that rather than getting 3 episodes, I would be getting 1. And that has both disease benefit in terms of health benefit in terms of reducing disease, but also economic benefit in terms of saving the expenditure and the productivity in the household. So that proportion of 30 to 40% shouldn't just be seen as an absolute. It should be seen relative to the burden that communities face. The other thing about the malaria vaccine, which is really fascinating, is that it also reduces all-cause mortality. In other words, the child experiencing diseases and different death risks or risks to their lives, there is a protective benefit giving the malaria vaccine to that child. So it's not just about malaria, but it also helps to reduce the risk of that child dying from other diseases as well.
incredible, incredible. The work that Malaria Consortium does, it's not just addressing malaria, right? It's a whole host of other diseases and other health issues as well. Can you quickly go into describing the work that you do across the different health issues that you support?
So our core business or our core focus is malaria. But in addition, we look at the health inequities that communities are facing, and we look at the capabilities that we have to address malaria to see how to use those capabilities to address other diseases. So in Cambodia, we have worked extensively with our government partners on the village malaria worker network, and that is the bedrock of malaria elimination in Cambodia. We have also had the opportunity to train and work with stakeholders to reach mothers who are at risk of cervical cancer, because that is one of those conditions that we've seen. It's it's vaccinatable because you can give a HPV vaccine to young girls that can prevent them getting cervical cancer, but that ability to reach those households, especially households in very hard to reach communities, is not happening. By working with our partners, with governments, we've been able to launch a program to use our village malaria health worker network to reach communities, to reach girls and their parents, to be able to increase their awareness of the risk of cervical cancer and the value of HPV vaccination, and then referring them to the right locations where they can get those vaccines. So we use our capability in delivering malaria tools to hard to reach populations to be able to reach them with other tools as well, with information that allows them to be able to make decisions in terms of how they use primary healthcare services. And then we do research, trying to understand, behavioral practices, understand acceptance, and some of that information can go beyond malaria because communities look at health more holistically than just one particular disease.
Of course. And that's the demonstration of the system in place, right? That you can leverage the system to support other diseases, cervical cancer in this instance, and the mechanism for vaccines and immunization through this place as well. So, look, it's been an incredible conversation, James, and I'd love to get your last message for any Australian donors who would be considering making a gift or who may be hesitant to giving to malaria because they think it's too big of a problem, for instance. What were your words for any Australian donors who might be listening at this moment?
My message would be no gift or no donation is too small. What I would encourage is be consistent. Think about the end game, how we eliminate malaria and contribute to health in children and potentially, I would say, adults as well. And we should not give up because there will be challenges, there will be threats, but organizations like Malaria Consortium and others are determined to see the end of these diseases and to contribute to both child and adult health. So, make a gift, make a donation. Nothing is too small. What I would encourage is just be consistent. Thank you.
Right. Well, so great to chat with you, James, today and learn more about your work and your life's mission to eliminate malaria.
Thank you, Liam. I appreciate it. And look forward to continuing the conversation and the partnership.
Thank you.
Thank you.